So Chris, you want to start with kind of talking about in your practice, what are the most common indications, why you get these Mediports, where they come from?
Yes. So by far and away, most common indication is malignancy. And so we're putting these in for long-term venous access for chemotherapy. By far and away, that's like the large majority of our cases. Every now and then we'll get a sickle cell patient. But for 99.9%, it's all onc patients.
Yeah. I mean, I guess the other cases are people who, for whatever reason, are hard sticks. People are getting, frequent blood transfusions, anemic patients, stuff like that. But yeah, you're right. For the most part, it's for malignancy. Any contraindications to getting a Mediport place where you might say, this patient should probably get a PICC line or some other kind of access before a Mediport?
Yeah, for me, the most common contraindication that comes up in my practice is if I suspect there's a current infection. So if for some reason they present as an outpatient and for whatever reason they describe an active infection, or they're on antibiotics currently, or they've just started on a round of antibiotics, if they can wait, I'll reschedule them. If not, if they have chemotherapy happening that afternoon or later that week, then I'll place a PICC, let them finish out their antibiotic regimen, and then bring them back and put in the port. I've seen some other, I don't know if they're contraindications, but it certainly makes life a little bit more difficult, is if someone's had there's no place to put the port. I think maybe you've probably seen some patients who have terrible radiation burns to their chest. And so you have to get a little bit more creative about where you put the port. That can come up. Mastectomy patients, although I still think it's reasonable to find an area to put the port, but that can present a challenge. And then as far as, I think one of the things that gets put in for anticoagulation is bleeding diastasis, but I've never not put in a port because I was worried that they were going to bleed out after or during the port. I don't know about you.
Yeah, the coags, I definitely like them to be off of, I follow SIR anticoagulation guidelines, but, we'd standard would be to check the INR, and, PT, PTT. Ideally INR is less than, 2.0 for me. Because what I've seen happen before, this actually happened in fellowship, is somebody's on Plavix and aspirin, and you put the port in and they come back with a hematoma in the port pocket. And I've seen that happen, and it can get messy, where then the patient comes back, they get a big Goomba over their chest, and, you're like, okay, what do we do now? Do we take this port out, or we try and get this hematoma to settle down? And that hematoma can get infected. So I'm kind of fortunate. I saw that early on in fellowship, and so since then I've been pretty strict about the, at least making sure that they're off anticoags ahead of time, and also just checking the coags.
So do you routinely check coags before all ports? Okay. Yeah. See, that's maybe where I differ. I stopped checking coags with port placements, and unless they have a history of being on something that I think they're going to, if they have if they're on Coumadin for whatever reason and they haven't held it, or they've only held it for one day, then yeah, of course I'll check it. If I have any reason to think that they're going to be coagulopathic, but otherwise routine patient, routine onc, I'm just going to push ahead without knowing the INR or the PT.
Yeah. Yeah. And, like you said, some of these, they're cancer patients, so they can have coagulopathies. So granted, those are more thrombogenic, but coagulopathies, but still, I like to get an idea, just a baseline. And it's, they're already getting usually lab work, when they come in, a CBC and BMP, as part of the outpatient workup at these hospitals I'm working at. So, it's usually just part of it. And I definitely check before, I go into do the procedure.